All right, we'll get started. So, we did case study 1 last time. We'll finish off here the rest of these. I added 2 words here to this case study, so not that it's, significant, big deal, but we do like to know in stroke cases, especially whether the patient is right or left-handed. Okay, so I just thought I'd add that in because why do you think that's important? If they're right-handed, it means they're almost certainly language dominant in the left hemisphere. If they're left-handed, they're still probably language dominant in the left hemisphere, but we would at least consider that they might be in the right hemisphere. So this is a 63-year-old right-handed woman who had sudden onset left-sided weakness that occurred 12 hours ago. She didn't want to come to the emergency room and told her son that she only had a virus. On examination, she has a left homonymous hemianopsia and moderate left-sided weakness in the arm, mild in the leg. So as a big picture, left homonymous hemianopsia, where's the lesion going to be in that case? Big picture is it has to be behind the chiasm, right? If it's in the optic nerve, you'll get monocular vision loss. If it's optic chiasm, you get that bitemporal visual field loss. So this has to be posterior to the chiasm. So it could be optic radiations, occipital lobe, but has to be further back. So reflexes are increased in the left arm and leg, and the patient denies having any weakness. And when the left hand is held in front of her eyes, she denies that it is her own hand. And that's kind of a strange thing. Okay, so any thoughts on this one? What might be going on? First, can we localize it? You can start with very big picture if you want to. It has to be right hemisphere, right? She's weak on the left side. Doesn't sound like she has a language problem, right? So this would fit also for a non-dominant hemisphere lesion. She's right-handed, so left hemisphere seems to be all right. Maybe let's start with something, again, big picture here. Whenever something happens sudden onset, what do we think about in neurology? Something vascular, right? This is not going to be a tumor or something like that. So this would be how a stroke presents. Now, if you had to pick a vascular territory for this, what do you think would be most likely? Middle cerebral artery supplies motor cortex, right? Also supplies the optic radiations. Okay, so this has a lot of features of a middle cerebral artery stroke, right middle cerebral artery stroke. Now there could be some other things in the differential. You can have a bleed that can occur suddenly and that can sometimes be difficult to sort out. Okay, but it sounds like a stroke or a hemorrhage in the brain, and it's right hemisphere, and blood vessel we think is most likely middle cerebral artery. Now let me just say a couple of things here about the non-dominant hemisphere. We've talked a lot about the left hemisphere and aphasias, but you get a very different picture when the right hemisphere is involved. Okay, and this patient exhibits a couple of things on exam. One is anosognosia. Anosognosia is denial of illness. And so the patient says, well, I've just got a virus. I mean, you would think, boy, if you're weak on one side of the body and you can't see off to one side, why would you be downplaying that? And then to even deny that the arm and leg are weak, again, that's all part of the denial of illness, and that's very characteristic of right hemisphere lesions, and in particular, right parietal lobe lesions. That seems to be the most important. If you had to isolate it to a lobe, it would be right parietal lobe. Okay, so we see this a lot in patients that have right hemisphere strokes, especially middle cerebral artery distribution, where despite having significant difficulties, patient's telling you there's no problem, I'd like to go home. Asomatosognosia is denial of the involved body parts. Okay, so the patient has weakness on the left side, And I've seen this many times. You hold up the weak arm, and the patient's looking at it, and they say, nope, that's not my hand. Okay? And the most interesting one I had, I don't think I told this class this, but I was showing a patient their hand, and they were saying, no, that's your hand. And then they looked a little while and said, how did you get my watch? So they recognized their watch, but not their hand. Okay? So again, left hemisphere, you want to be looking for an aphasia. Wernicke's, Broca's, global aphasia. If we've got a big right hemisphere lesion, these are the kinds of things that we're looking for. Right hemisphere lesions, so they can have a right visual field defect, but they also can have what's called a contralateral hemispatial neglect, where they essentially deny that anything exists on the left side. Okay, and that kind of fits along with the denial of the involved body parts, the denial of illness. And so if you ask a patient then to draw a clock or any kind of a drawing, you might get something like this, where everything is only put on one side of the clock, but not the other. Okay, and so again, you ask the patient to draw a face or something like that, and so the lesion's on the right, so it's the left side when they draw something that tends to not show up. When I was a neurology resident, I used to have an attending that would go in, and he would take off half of his lab coat, so you'd only see it on one side, and they would ask the patient, is anything strange about the way I'm dressed? And they wouldn't recognize that. Or I've seen a woman that had this stroke, and she really wanted to put makeup on in the hospital, and she didn't put it on one side of her face. Okay, so this is what we see with a right MCA stroke. Now, what I'm going to explain here, I just want to first clarify, I'm not talking about vision with this slide. Okay, we're not talking about the homonymous hemianopsia, but rather the attention to the opposite visual field. All right, so here's how this works. Normally, so here's your left hemisphere. Again, we're not talking about attention or vision. We're talking about attention and arousal for visual space. And so the left hemisphere maintains attention and arousal for the right visual field. But notice the right hemisphere maintains attention and arousal for both visual fields, both the left and also the right. Okay, so if we have a left hemisphere lesion, let's start with a left hemisphere lesion. So here's the lesion right here. Now the right hemisphere is still able to maintain attention and arousal for both fields of space. So there's no hemispatial neglect with a left hemisphere lesion. Okay, but now if we have a right hemisphere lesion, you now only have the left hemisphere maintaining attention and arousal for the right side of space. Okay, and so that's why the right hemisphere lesion is the one that produces this kind of neglect on the opposite side. Okay, so it's a unique function of the right hemisphere that it does it for both left and right hemispatial fields. Okay, so it's a kind of a unique finding. I have a great video when we do our stroke lecture next year that I'll show you of a patient with a big right MCA stroke. All right, so describe the abnormality on this MRI scan. First of all, do you remember, is this a T1, T2? Yeah, this is a T2. The CSF is bright. This is actually an old right MCA stroke, so kind of fix this in your mind. This is what a middle cerebral artery stroke looks like. This would be one of the more common images probably that you'd need to be able to identify on a board exam. And middle cerebral artery strokes are very common. Okay, and so this is what they look like, and over time when someone has a stroke, it kind of just becomes like a fluid-filled space. And so that's why this has pretty much the same signal characteristic of the cerebral spinal fluid. Okay, just tells you this has been there for a while. So this is what a middle cerebral artery stroke looks like. And now it's often helpful in the acute setting to know where is the lesion specifically. Could be carotid artery, but in this case, if we do an MR angiogram, so here's the basilar artery, here are the posterior cerebral arteries. Okay, but when we look up here in the anterior circulation, we've got a nice left internal carotid and a nice left middle cerebral artery. But notice when you come over to the right, just compare the difference, how much loss of blood flow there is here, and it looks like there's a focal narrowing right here. Okay, so next year when we talk about stroke, it's really exciting, the developments in stroke just in the last 3 years. The changes are dramatic because we can now, in an acute large vessel stroke, we can do what's called a mechanical thrombectomy, where you can actually go in and you can take that clot out. And so we really want to diagnose this as soon as possible when we found a lesion like that. Okay? So any questions on this case? Yes? Yeah. Yeah, so can they feel? Well, remember that the middle cerebral artery also supplies the postcentral gyrus, and so they probably will have some sensory loss. And again, you don't need to know this, we'll talk about it next year, but they usually can feel, some touch. But what's real interesting is if you touch them in their left arm, they might say they feel something, but if you touch them in both the right and left arm at the same time, then they usually deny the left arm, and they will say, well, you only touched me in the right arm. So there's some kind of unique things that you get on the sensory exam. Remember, just don't forget when you're looking at this, I will not have these labeled, but you need to remember what is right and what is left. Yes? Okay, so if the patient is denying illness, how do you convince them that they need treatment? Well, in a situation like this, it's almost always the family is going to be there, and you're showing them the stroke on the screen, and the patient's going to be admitted to the hospital. I've not had difficulty with, and the patient is unable to walk or to. It's not like they can just get up and walk out of the hospital because they have weakness. The denial of illness and all of that is usually just seen in the very acute phase. So usually by like day 5 or day 7, they now are beginning to have insight into what's going on. Yeah. Unlike an aphasia, which tends not to improve so much. By the way, it's just an interesting thing, again, not that you need to know this, but so these patients have left-sided weakness, all right, and they're kind of denying that space. And so an interesting finding, and this was actually I think a graduate student at UC Davis that was just curious about this and asked the neurologist, what happens if these patients try to clap? And the neurologist said, well, I have no idea, let's find out. So we actually did it on a few patients. And if you have someone that is just weak, okay, from something else in their arm, and they try to clap, they do this. They'll kind of reach over and clap their hand. But if you are denying that this exists, then patients with an MCA stroke will do this. They'll actually think the other hand is clapping. So there actually is, because of that student just thinking of that, there's a clapping sign that we see with middle cerebral artery stroke. Okay, and then just to remind you that in acute stroke, this is not this patient, but acutely we want to do diffusion-weighted imaging and ADC on our MRI. And this is how we can detect, just confirm that we're dealing with acute ischemia. So these bright images here are diffusion-weighted. So remember, on diffusion-weighted, we get this hyper-intense, bright signal. Okay, and if we're not sure, well, is it ischemia, you do the ADC imaging, which is dark. So bright on diffusion-weighted, dark on ADC, that's acute ischemia, our most sensitive test that we can do. Okay, now, so I told you that CT is not very sensitive for acute stroke, but there are some things that we look for on the CT in acute ischemia. And I'm sorry, I keep asking you to do that. I should think of it ahead of time. Would you mind one more time just bringing the lights down? Thank you, because this is a little hard to see. So there are more subtle things that may show up and may not show up on a CT in acute ischemia. Just looking at this, can you see any difference? That's perfect. Thanks a lot. Can you see any difference here between the right and left hemisphere? Yeah, look at the sulci here. They really stand out. Here's a Sylvian fissure. But it's all kind of a blur over here. And so you want to look from side to side on a CT. And so what's happening here is there's really, we call it gyral edema. There's a little bit of swelling. And that causes the sulci to become obliterated. Okay? And so we get a little bit of edema, and this obliteration of the sulci we call effacement, sulcal effacement. Okay, so this would be what you might see early on a CT, and just if you kind of, sometimes these can be quite subtle, and so we want to look very carefully side to side on CT scans. This would be normal. If we look from side to side, it looks really symmetrical, sulci are symmetrical, so that's a normal appearance. Okay, and just as a reminder, there will be no questions on any of the labeled structures, but every single one of these case studies, well, not every one, but I will be showing you these exact same slides for the exam. So make sure that you've are aware of the cases. All right, so number 3, 34-year-old man develops a sudden onset headache while at work. He described it as the worst headache of his life. Now, we haven't had our headache lecture yet, so I realize you're not going on a lot of information, but just throw out some things here that could cause a bad headache that you might have heard of. Not having your coffee, that's true. Okay. Well, that is actually a very common cause of headache. The sudden onset would make it a bit kind of in a unique category. I heard migraine. Certainly migraine can, you mean, if you have migraines, you're going to have a worst migraine of your life, right? But it's the sudden onset that should maybe make us think of something else. Now, someone mentioned an aneurysm, and again, our lecture for next year, but aneurysms do not cause headaches as a rule unless they rupture, right? So better to say a ruptured aneurysm. What did you say? Meningitis. Meningitis would be another good one. Now, meningitis usually tends to, come on over a period of time. Now, it can be, over a short period of time. But when someone is just normal and it's like, boom, there is a sudden horrific headache, that is suggestive of a ruptured aneurysm. So that would probably be the first on our list. But yeah, meningitis, migraine, other things would all be on the list. All right. So on examination, he is sleepy and at times difficult to arouse. What did we say last time that should always raise concerns about? Increased intracranial pressure. There'd be a differential, obviously. Maybe he took some pain medications that were sedating. But you got a sleepy, confused patient. Remember that there may be increased pressure in the brain. When his neck is flexed, he has severe pain. What does that suggest? What do you do when you bend your chin down to your chest? You're stretching meninges, right? So anything that would cause meningeal irritation. And so we mentioned 2 of them already, right? Meningitis, but what else? Blood, subarachnoid hemorrhage, right? When an aneurysm ruptures, where does the blood go? It goes into the subarachnoid space. And so severe pain with neck flexion should make us think either of a meningitis or a subarachnoid hemorrhage. So over the next 20 minutes, he becomes unresponsive. We're concerned about this patient now, right? I mean, that's not a good sign. Okay, so that would further support, if we're concerned about increased intracranial pressure, that maybe now the patient is having some herniation of the brain, and that's why they're not responding. Okay, so we've listed our differential, and what, you're in the emergency room, this patient just kind of lapsed into a coma. What do we want to do for this patient? What would be the CT? We said bleed is our number 1 on the differential, right? So whenever we're thinking hemorrhage is most likely, CT is always the right answer. Okay, so we need a CT scan. All right, and so here's our CT. So what do you see looking at this? See a lot of blood, right? Remember, 2 things look bright on a CT, calcium or blood. So do you remember what this space here is called? quadrigeminal plate here, the quadrigeminal cistern, quadrigeminal cistern, which outlines the midbrain. So these are the superior colliculi, they're the cerebral peduncles, this is the midbrain. All right, so we've got a lot of hemorrhage there. This is subarachnoid space. Okay, all of this is subarachnoid space, and there's so much blood in the subarachnoid space that it's backed up into the ventricular system. So we have blood here in the third ventricle and in the lateral ventricles. Okay, this is actually a shunt that was placed in here to try to relieve the pressure. So this is what a subarachnoid hemorrhage looks like. Okay. Now, fortunately, CT is very sensitive for this. We almost always pick this up on a CT, but let's just say, kind of theoretically here, you did a CT, you were thinking it was subarachnoid hemorrhage, and your CT didn't show anything. Is there another test you could do to try to diagnose that? Yeah, lumbar puncture, because the subarachnoid space, remember, continues all the way down into the lumbar cistern. Okay, so if we're looking for blood, or if our CT is negative, maybe we're thinking now it's meningitis. Then you do a lumbar puncture. You can look for red blood cells for hemorrhage. You can look for inflammatory cells and try to diagnose the patient if they have a meningitis. So lumbar puncture, in answer to question 2, would be the next step to do if your CT was unremarkable. Okay, but in this case, we've got an obvious cause. So what did we say causes subarachnoid hemorrhage? An aneurysm. Now, this doesn't show us where the aneurysm is. We need to do other tests to find out where it is, but this just tells us the patient has an aneurysm somewhere that ruptured. Okay, so what do we do to find the aneurysm? Well, we can do angiogram studies. This is a conventional angiogram, and so here we can see we've got a really large aneurysm there. And of course, we get neurosurgery involved in these cases because there are lots of surgical options. We'll talk about this next year. So we need to clarify where the aneurysm is so they know where to operate. Okay? Any questions on that case? This would not be a very good prognosis if we've got a patient now in a coma with such a massive hemorrhage. But you would still try to, take care of the aneurysm and do what you can. Now, I put down there at the box at the bottom, we don't have a case study on this, but since it's just one of the highest yield things on radiology that we can ask about, I just thought I'd show you a picture. Huntington's disease we'll talk about next year. It basically it causes a dementia and a pretty significant movement disorder. And so I just wanted to, won't ask you about it now, but kind of plant the seed for next year that Huntington's causes diffuse atrophy of the brain. Can you appreciate that kind of around the periphery, these sulci, here's the Sylvian fissure, are larger than they should be. So this indicates there's atrophy. But what really stands out is there's no caudate nucleus. Okay, the caudate bulges into the lateral ventricle. And caudate is selectively involved in Huntington's disease. And so remember, the caudate is part of the basal ganglia circuitry. And so that's why patients with Huntington's disease have this significant movement disorder. Okay, so that's for next year, but trying to think ahead about board questions. All right, let's go to case number 4. We have a 31-year-old woman presents with double vision when she looks to the left. This occurred 2 days ago. Okay, so double vision when she looks to the left. Give me a couple of things that could be. Could be an INO. Internuclear ophthalmoplegia, maybe the medial longitudinal fasciculus. What else? Yeah, increased intracranial pressure affects especially cranial nerve 6, right? Or you could have a 6th nerve palsy on the left, right? So when she's looking to the left eye is not moving. Or maybe she has a right 3rd nerve palsy, which controls the medial rectus, so the right eye can't move over. Okay, so there are a lot of different possibilities. Does her age suggest maybe one of those might be more likely than another? Yeah, multiple sclerosis, which often affects the MLF, remember, is something that occurs in young people. Okay, so that's a pretty good list. 3rd nerve palsy, 6th nerve palsy, MLF lesion. So this occurred 2 days ago. 6 months ago, she had difficulty seeing out of the right eye as if a cloud were over the eye. Okay, so again, big picture, blindness in one eye. Where is the lesion most likely? Now it has to be anterior to the optic chiasm, right? So it's either optic nerve or there's a problem in the eyeball itself. Okay, so it has to be anterior to the chiasm. This lasted for 4 weeks and then resolved. Now 2 years ago, both legs were weak and numb for over a month, but she was in Europe and did not seek medical attention. These symptoms also resolved. All right, so the general rule is when someone has bilateral leg weakness and numbness, the lesion's almost always spinal cord. Okay, so here we've got, like 3 different lesions that come and go. So what does that suggest to you? Sounds like multiple sclerosis. Got a young patient with things that are, seeming to attack at different times, different parts of the central nervous system. So this is a really good story for multiple sclerosis. So on exam, when she looks to the left, the right eye does not move past the midline, and there's some nystagmus in the left eye. Yeah, really typical for an MLF lesion, right? So remember that if you've got a right MLF lesion, it's your right medial rectus that isn't going to work well. So when the patient looks to the left eye goes out, the right eye doesn't follow. And so then the brain tries to bring the images together, and that's why you get a little nystagmus in the left eye. Okay? So need to remember what an internuclear ophthalmoplegia looks like. Looks just like this. So remainder of the exam is normal except for hyperreflexia in the legs with bilateral extensor plantar responses. Okay, why do you think she has that? Well, she had that episode that affected her spinal cord some time ago. So even though she feels like she's pretty much back to normal, you see some exam evidence of that previous problem. Okay? So what's the differential diagnosis? Well, there is a differential for multiple sclerosis, but it includes some other rare things that I don't expect you to know about right now. So let's just put 1 through 5 as multiple sclerosis. We won't have a real differential. Can a single lesion explain the ongoing symptoms which the patient is having? No. And that's always not satisfying as a neurologist. We want to find one lesion to explain everything, but that's the hallmark of MS. You get lesions all over the place. We can't localize it to just one place. We've got scattered lesions here and there. Okay, so you're seeing this patient in clinic. What type of scan do you want to get? Okay, so not just MRI, but FLAIR. So yeah, well, we want an MRI scan, right? It's going to be much, much more sensitive than a CT. So remember, MRI is, if you're in neurology rounds or something like that and you're asked what image do you want to get, usually say MRI scan, except if it's a hemorrhage. So we want an MRI scan. All right, so where are the lesions here? Some bright spots. Well, these are in the white matter. Okay, they're not out, the cortex out here looks pretty good. So these are white matter lesions. And multiple sclerosis is a demyelinating disease, central nervous system demyelinating disease. Okay, so this will be very consistent here with multiple sclerosis. And the other thing we can do is, this is a T1 image where we've given gadolinium. And notice here that this optic nerve lights up. Okay, so remember the value of giving contrast. So when someone has optic neuritis, which is what involves the optic nerve in MS, we can actually see objective evidence of that when we do an MRI scan. Okay, so we've got demyelinating lesions of the optic nerve and in the white matter. Okay, and again here is, you mentioned FLAIR and T2, so we can see lots of demyelinated lesions, but let me just show this here on this slide. So again, the reason that FLAIR is the most helpful sequence for multiple sclerosis is that the CSF now is dark, and so the bright spots in MS, or I should say the demyelination in MS, for some reason they always tend to line up around the ventricles. And so this would be just really classic for multiple sclerosis. And so on a flare, it's really obvious. Here's just to show you the difference between T2, which is on the top, and flare, which is on the bottom. This doesn't show up that well. But the demyelinating lesions around the CSF on a T2, they just don't jump out at you quite as much, probably mainly because the CSF is bright here. But on a flare image, just look how much more dramatic that is. Okay. So again, when you do an order for a multiple sclerosis, the radiologist will automatically do these different images. So do a T2. So diagnosis is multiple sclerosis, and we'll go into treatment and all the things we can do for MS next year. All right, number 5, 55-year-old man complains of gait instability, progressive over the last 6 months. More recently, he's had shooting pain into the right arm, primarily in the shoulder area, and his right arm seems weak. Okay, so what do we think of? Shooting pain in the arm with a weak arm. Sounds like a radiculopathy, right? Which usually has that kind of shooting quality. The arm is weak. On exam, he has weakness in the right arm involving the deltoids and biceps. Do those two muscles have something in common? It's not the same nerve, is it? Deltoids, what supplies deltoids? Axillary, what supplies the biceps? Musculocutaneous. So it can't, we don't want to put a lesion here and a lesion there of two separate nerves. So back up into the plexus and roots. What do those two muscles have in common? They're both C5, C6 muscles. Okay, so that would suggest that this is probably a C5-6 radiculopathy. The right biceps reflex is absent. Okay, so the roots are lower motor neurons, right? So if you have a C5, C6 radiculopathy, you're going to lose the reflex to the biceps. But now the triceps reflex is very brisk in both arms. Reflexes are 4+ in both legs with sustained clonus and bilateral extensor plantar responses. Vibration and proprioception is decreased in both legs. Okay, so it's C5, C6 nerve root, but it's also what else? Spinal cord, right? We've got something not just compressing the roots, but compressing the spinal cord. And so if you compress the spinal cord at C5, 6, remember that everything below that is going to be affected. Your descending upper motor neurons are knocked out or destroyed to a certain extent. And so below C5, 6, everything is going to be upper motor neuron. So triceps, remember, is mainly C7. That's below C5, C6. So that's why that reflex is brisk. And of course, all of your leg reflexes are below C5, 6. So that's why we have all the upper motor neuron findings in the legs. Why does he have the loss of vibration and proprioception in both legs? Posterior columns at C5 have also been knocked out. So we have something pushing on the cord. We have swelling throughout the cord at C5, 6, and it's interfered with lots of pathways. Okay, so this is a cervical myelopathy. Okay, myelopathy is the big term for spinal cord disease. Can be caused by a lot of things. In this case, it's in the cervical cord, so we call it a cervical myelopathy, and we can be very specific and say that it's at C5, C6. Okay, so we've localized the lesion. What imaging do you want to do now? MRI. Not dealing with a bleed or something like that, so we need an MRI scan, which can nicely show us a lot of the anatomy here of the spinal cord. So here is a sagittal MRI scan, and what we see here is there's a nice protective CSF coat, this subarachnoid space that coats the spinal cord, serves a very important protective function. This is how it should look throughout the entire length. But notice here, something happened. Okay, and so if we look further here in other images, we can see there's a big disc herniation, and now we see a little bright spot right here within the spinal cord. So this is swelling in the spinal cord. So this patient has a disc herniation at C5, C6 area with swelling in the cord. All right, so that's why at the level of the lesion, we've got the roots that are involved. Okay, but the cortical spinal tract, for example, as it's traveling down here, the signal can't pass very well through this. So that's why we get lots of upper motor neuron findings below the lesion. The posterior columns that are conveying vibration and proprioception up, they get disrupted, and so that's why there's a loss of vibration and proprioception. Okay, so this, again, we localize the lesion clinically, we confirm that with MRI, and what do you think this patient needs at this point? Surgery, right? So you would contact neurosurgeons in general tend to operate on the neck. Orthopedic surgeons usually operate on the low back. So you'd call a neurosurgeon typically for something like this. Okay? And these can respond well. You remove the disc material, you relieve pressure here, and patients can have a really good improvement. Okay, so this would be a more normal looking MRI of the spine. I've got a few little disc bulges here that are indenting here on the subarachnoid space, but it's not impinging here on the spinal cord at all. So this is how it would look in a more normal situation. Okay, number 6. We've got a 59-year-old man complains of progressive hearing loss in left ear over the last year associated with tinnitus and dizziness, which occasionally has a spinning sensation. So medical term for that is vertigo. During the last 3 months, he feels that the left arm and leg are clumsy. And he's also noticed that the left face is droopy and tingly. Okay, can we tie these things together just from the history? Sounds like something's wrong with the 8th nerve, right? That would cause vertigo and hearing loss. And how do you relate the facial nerve 7 and 8? They're in the Cerebellopontine angle, right? And why do you think he has left arm and leg clumsiness? Cerebellum is right there, and the left Cerebellopontine angle. So if we have something in that one place, it's going to affect the cerebellum and cranial nerves 7 and 8. So on exam, he has decreased hearing in the left ear. He has weakness of the left upper and lower face. So what's the significance of telling you it's forehead and lower face? It's lower motor neuron, right? So it's, in this case, suggests that, yep, we've got a facial nerve problem. So a lesion's not up in the brain, it's the facial nerve itself. Facial sensation is normal. He also has some nystagmus when he looks to the left. Why do you think he has nystagmus? Well, if you've got a problem with the 8th nerve, that's conveying vestibular information into the brainstem. So we have a mismatch of vestibular input into the brainstem, and so that is one of several things that can give you nystagmus. So this, in this case, would suggest, yep, it's the 8th nerve again that's affected. He has no weakness. Reflexes are symmetrical, but there's ataxia with finger to nose and heel to shin testing on the left. Okay, so again, what we thought is that, well, the cerebellum is there. So we've got something pushing on the left cerebellar hemisphere. Okay, so we think we've got a Cerebellopontine angle tumor or something there. So what if we did corneal reflex testing? And so anytime we've got cranial nerve 5 or 7 involved, this is a good test to do. Remember, the normal physiology is you touch the cornea lightly with a wisp of cotton, which actually activates both facial nuclei, so both eyes should close. Okay, so in this case, let's say that we're touching the left cornea on the side where he has his facial weakness. Okay, so there's no facial numbness, so we anticipate that the trigeminal nerve is working okay. So this goes into the principal or chief sensory trigeminal nucleus. But because we've got a lesion right here, we're not going to get a direct response. So you touch the left cornea, the left eye is not going to do that much. Okay, but because both facial nerve nuclei are stimulated when you touch one cornea, the opposite side of the face or the eye will close on the opposite side. Okay, so in this case, if we touch the left cornea, we're not going to get a direct response, but we'll get an intact consensual, or the opposite side, opposite eye will close. Okay, what imaging study do you want? MRI, right? So here's an MRI where, we've got an obvious mass right here. So this is the Cerebellopontine angle. We can't visualize it very well, but 7 and 8 are coming out in this space right here. So the tumor originated here and involved cranial nerves 7 and 8, and now it's extending into the cerebellum, and so that's why the patient has the ipsilateral ataxia. Okay, so these can be resected. My dad had this tumor when I was a neurology resident, actually, and he was complaining of hearing loss, and I remember examining him, and he had some ataxia on that side. So we got a scan, and sure enough, he had an acoustic schwannoma. Okay, 3 more. Number 7, a 78-year-old woman who's had progressive left arm and leg weakness over the last 4 months. She did not seek medical attention. While shopping, she developed a rhythmic shaking of the left arm and leg for 10 seconds, followed by a generalized tonic-clonic seizure. During this seizure, her eyes were looking to the left. Okay, so you actually know the anatomy to understand this, so we're going to go over this here in just a little bit. First of all, just to make a big point, when someone has progressive weakness on one side of the body over 4 months, does that make you think of anything? Or does it suggest it's not something? It's not going to be a stroke, right? This didn't come on suddenly. It's progressive. And so this would make us think of a mass lesion. Okay, so this would be a good presentation for a tumor. There would be other differentials, but certainly a tumor would be a real concern, in this case. Okay, think of a seizure as kind of the opposite of a stroke. A stroke destroys the function of neurons. They don't work very well. A seizure is like, it's like an electrical storm in the brain. You're overstimulating pathways. Okay. So on exam, she's sleepy, difficult to arouse. Well, again, that could be increased intracranial pressure, but we'll discuss next year that after someone's had a seizure, they're often sleepy and difficult to arouse. So in this case, it could just be because she had a seizure. Okay, she has, should be just moderate weakness in the left arm and leg with hyperreflexia in the left arm and leg. Okay, so in terms of which hemisphere is involved, it's right hemisphere, right? She's weak on the left side. And so now let's try to explain here the seizure. All right, so a familiar diagram here, I hope. Here's the corticospinal tract. Okay, in this case, in the left hemisphere, moving muscles on the right side of the body. And here are the frontal eye fields in blue. Okay, so remember, the left brains always want to drive your eyes to the right. The right brains always want to drive your eyes to the left. Normally, they're equally counterbalanced. Okay, and so we've talked about how does the left brain move your eyes to the right? It does so by talking to the opposite PPRF, 6-nerve complex. That moves the right eye to the right. Gets the left eye to move to the right by communication here with the MLF to the part of the 3rd nerve nucleus that moves the medial rectus. Okay, so that's review. So what happens in a seizure? In this case, since the drawing here is showing you the left hemisphere, if we have a seizure starting in the left hemisphere, it's going to stimulate, drive these pathways. So with regards to the corticospinal tract, if you excite this pathway, you're going to get shaking on the opposite side of the body. Okay? If you excite the frontal eye fields, you're now going to drive this pathway. Okay? And so the eyes will get pushed to the right. Okay? So when you have a seizure that originates in one hemisphere, it causes the opposite side to shake, and it drives the eyes to look at the shaking arm and leg. Okay, so this is a really common board question, I would say. The seizure is described, you're asked to localize the lesion. So in a seizure that originates here in the frontal lobe, the eyes will look at the opposite shaking arm and leg. Okay. So in our case, the lesion's in the right hemisphere, so the left side of the body shakes and the eyes look at the left arm and leg. So we know where we're looking for a lesion. We're looking for something, in this case, in the right frontal lobe. Okay? So here is an MRI scan. This is a T1 MRI before contrast. And we can just kind of see, boy, it looks like there's something going on there. This doesn't look quite normal. Okay, and so we give gadolinium, which, remember, is very helpful for anything that involves destruction of the blood-brain barrier. And there we can see a mass right in this area. Okay, and this is what we call a ring-enhancing mass. Can you see it kind of like a ring all the way around? Okay. What's happening here is that when you have a tumor, whether it's a primary or a metastatic tumor, these immature blood vessels tend to form around the tumor. Okay, they're immature, they're leaky. And so when you give contrast, that's why it tends to light up a lot around the periphery. Okay, so there's a differential for ring-enhancing lesions. It's not always a tumor, but that would be the most likely cause. Okay, so here's just another example on a CT. Non-contrast, what we see here is a lot of swelling. Okay, when we give contrast, now we see ring enhancement. And so in this case, the patient had what's called a glioblastoma, which is a malignant brain tumor that has a very poor prognosis. But patients often have a ring enhancement like this. Okay, so tumors tend to cause progressive weakness if the lesion involves the motor cortex, and frequently it's a seizure that will end up bringing the patient to the emergency room. Okay, we need to get through our next two cases here in a few minutes. So case 8, an 86-year-old man has had progressive memory loss for the last 4 years, was finally placed in a nursing home because he could not care for himself, and he frequently wandered from home and could not find his way back. Okay. Again, we haven't had a lecture on this yet, but what does it sound like? Yeah, big categories: dementia, and Alzheimer's is far and away the most common cause of dementia. So on exam, he's pleasant and socially appropriate, which is really characteristic of Alzheimer's disease. Superficially, you may not know anything's wrong with the patient. They're engaging, they're friendly. But when asked what year it is, he said 202. Although he has 5 children, he could not remember any of their names. He asked if his wife was here, although she'd been dead for 6 years. All right, so this is sounds like Alzheimer's disease. Wandering is very common. Getting lost is very common. What area of the brain specifically do you think is involved there? Hippocampus. Remember, your GPS center is in the hippocampus, and that's affected very early in Alzheimer's. So these patients, often an early finding is they're driving and they get lost. You know, you just lose that sense of direction. Okay, so where is the lesion? In Alzheimer's, it's diffuse cortical. Okay, we've got a lot of cortical neurons just drop out. And so here's an MRI scan in a normal patient. Notice the nice, healthy-looking hippocampus down here. Okay, and so a distinctive MRI finding in Alzheimer's disease. Look at this big temporal horn of the lateral ventricle right here. Huge space and just tiny little hippocampus there. Okay, so we have diffuse atrophy. The whole brain's affected in Alzheimer's, but if you see that very significant atrophy of the hippocampus, that's characteristic of Alzheimer's disease. Okay? So here's a CT. Notice diffuse atrophy, big ventricles. So is this hydrocephalus? No, not a true hydrocephalus. This is hydrocephalus ex vacuo. It would be a more normal appearing brain at this level. So the ventricles are big, but this is not, an obstructive hydrocephalus. Here's a true hydrocephalus, right? Big ventricles, not much atrophy. And this will be another hydrocephalus, true hydrocephalus. Big lateral ventricles, but the rest of the brain looks really good. Okay? So in Alzheimer's, it's hydrocephalus ex vacuo. Last case, 49-year-old woman who has a history of atrial fibrillation suddenly felt that she couldn't see well out of her left eye. Does atrial fibrillation, I don't know if you've learned about that yet, but is that concerning for a neurologist? Yeah, if your atrium is quivering, what happens? You can get clots that form on the wall of the atrium, and those can break off and go to the brain. So this is a major risk factor for stroke. Now, she felt that she couldn't see well out of her left eye. When driving to the emergency room, she ran into a garbage can, which was to the left side of the car. Okay, I put this in on purpose because, at least on National Board subject exams, it's always patients driving into garbage cans. They have the same vignette for forever, it seems like. So I want you to remember this, okay? So this would actually suggest that the problem is probably not in the left eye, okay? The patient probably has a left visual field deficit and can't see to the left side in either eye. And oftentimes when you have that, when you have a homonymous hemianopsia, patients will say, yeah, my problem's in my left eye. But we need to do the exam to find out, is it a left visual field defect, or is it really just a left, problem of vision in the left eye? So on exam, she has a left homonymous hemianopsia. And now it confirms this is not just a left eye problem. She's lost the left visual field in both eyes with macular sparing. Okay, what does that tell you about the lesion, macular sparing? Posterior cerebral artery. Okay, you see macular sparing, it's a posterior cerebral artery stroke. Because remember, the macular fibers back there have a dual blood supply, MCA and PCA. So if you've got macular sparing, it's a PCA stroke. Okay, so the most prominent feature of a posterior cerebral artery stroke is the visual field loss. Okay, so they don't tend to have much else on exam. Okay, so we showed what a MCA stroke looks like, and now you can fixate in your brain here. This is the distribution of the posterior cerebral artery. Remember, the posterior cerebral arteries wrap around the cerebral peduncles here, and they head back to the occipital lobe, and on their way back they supply the undersurface of the temporal lobe and then the occipital lobe. So the optic radiations and especially here visual cortex back here is affected. And here's the CT showing you the same thing. So this is what a PCA stroke looks like on a head CT scan. All right, good luck on this exam, and look forward to seeing you guys in August.